Dear Dr. Mihai Bedlov, I found that in the chatting area there is one of your questions to Dr. Kamaria from Malaysia. Do you want to repeat your question to Dr. Kamaria? Thank you.
My question is about solid or cannulated screw, but Dr. Kamarian told about it all of.
Okay, regarding, I have experience for both screws. Initial part, I use a cannulated screw, but the problem with the cannulated screw, I do have a fracture. I mean a broken screw, especially on the above the growth plate. Start my video. Okay,
Yes, I understand.
Yeah, I do experience. For solid screw, I just recently used the solid screw. So I think I need to monitor my patient first before I can say whether I've experienced it or not. But another issue is the way we put a screw into the bone. If we put into divergence, it's quite easy. I'm not sure why, but it is very easy for the, most probably is because of the stress. It's easy for it to fracture, to broken.
Okay, I understand you. Thank you very much.
Yeah. Dr. Mikhail, just now you did the titanium elastic nail for, if I'm not mistaken, a segmental fracture femur. Is it? I'm right? Yeah. How you control the instability or the rotational stability about that particular fracture?
In the case when you do correct osteosynthesis with elastic nails, rotation stability is good. But sometimes you can use end caps for nails for a more rotation stability. It's not a problem.
Okay, thank you.
I will, hi everyone. I will answer some questions that I think very interesting about ESIN. First of all, either when you choose to use ESIN, you have taken in mind that where's the position. Probably you all will be agree, and it's mostly easier to achieve the reduction with the ESIN coming from the thinner part of the bone. For example, if you have an ulnar mid-shaft fracture, probably it's easier to achieve the reduction with the ESIN coming distal than from proximal. So you are going with the ESIN from the thinnest part of the medullary canal, and in that way it's more easier to achieve the other part of the fracture with the ESIN. So I choose either the proximal or the distal entry point, depending on which part is the thinnest in the medullary canal. That makes me taking the decision. And also for the radial entry point, I'm mostly confident using the more dorsal entry point, because I have many cases with paresthesia after surgery, and that was at the very beginning of my practice, very many years ago. So when I started using this more dorsal entry point, no more complication I have seen. And the only very key point here is the correct pre-modeling of the nail. And especially when we treat, as I show you in the presentation, when the fracture is more metaphyseal, probably I will have to do this special bending at the second part of the entry of the nail that will give me maintaining the reduction. And also depends where were the deformity forces. For example, it's not the same fracture that is displaced volar than dorsal. So you always have to keep that in mind. And the last question about a scene, distal humerus, in the entry point, I am very confident to use them. Probably some of you are not, by both sides, because as I show you the polytrauma cases, the particularly thing that has the only one side entry point for humerus is that it's very critical how you prevent the nails. If you don't prevent them in a correct way, the reduction will not be good. And that is also easier to achieve when we use the both sides entry point on the distal humerus. And for distal humeral fractures, I have not used until now the ESIN method. I help some of the colleagues to use ESIN methods for supracondylar fractures, but till now the only case I remember that's a very high supracondylar fracture, that very unstable, very difficult, I decided not to use an ESIN method and I put into an X-fix. And the advantage of that is that the technique takes only 10 minutes to put it and you achieve the reduction. So thanks for the colleague that asked that questions.
For discussions, Dr. Gonzalo, for me, bilateral access point for humerus is very dangerous. I'm use only monolateral approach. Maybe do you have some indications for bilateral approach in this case?
Probably, as I told you, I think it's faster and easier because we are very used to use bilateral or two sides entry point, right? Because it's very similar to a forearm, and the S modeling in humerus at the beginning of the practice probably is not that easy for many colleagues. And if you take the correct take the correct cares about a mini open, probably to isolate the ulnar nerve and to leave the end part of the ESIN not too outside from the bone, and a correct straight cut. Till now, I don't have seen any complication or neurovascular complication on the medial entry point, and I use it very much also for supracondylar fractures. I use the both sides spinning way for too many fractures. Nowadays, I don't even do I always teach to my residents and fellows and also encourage them to learn how to palpate the ulnar nerves, also in healthy patients and also in patients with a supracondylar fracture with the elbow with too many edema, right? So, and when you try to precise to use your finger to palpate the ulnar nerve, and you achieve that, you are very confident to put into a key wire percutaneously, not doing the mini open. Obviously, the AOS recommend to use, but I do the same for the.
I'm using in the case of supracondylar approach only monolateral approach. And what about your complications in bilateral ESIN osteosynthesis of fractures of humer?
In what? Sorry, I didn't hear you. In OI?
What about complications?
Oh, I think more of the complication, and one of my message on the talk is learn principles, right, and use it in the correct way. I saw in the experience that most of the complications are due to the not correct use of the techniques. And as you showed very, very clear, I think the most common complication is due to an incorrect choose of the diameter of the nail. When you use too thin nails, you can see very early on the evolution of the fracture and a malunion probably, or the axis will not be correct. And other complication that you can see probably when the fracture is very unstable and you don't consider that, and you don't use, for example, an end cap, and the fracture start to the bone is not achieving or maintaining the length right, and the end point or the entry point of the nail is going outside. I think that is the most probably often complication due to the compression on the fracture site. And again, I think that it's because probably when you don't take the time to analyze correctly the patient and the X-ray, and you don't take the good decision on the OR.
I do have one question for our first speaker regarding the proximal femur osteotomy. Did he experience any problem with the two screw cannot fit into the neck of femur in his patients lah?
Pardon? If
Our first
you mean,
speaker, Dr.
Yeah, I'm here.
Yeah. Do
Sorry.
you have any experience regarding two screw, even you use a 3.5 pediatric hip plate, that your neck screw couldn't fit into, I mean, two screw cannot fit into the neck. And how do you do, I mean, to overcome that?
You mean if patient is too young, also the femoral neck is too small.
It's too small. Yeah.
So the two screw cannot fit in. Then I will choose 2.7 millimeter. Yeah, 2.7. Another options now is available. But yeah, first of all, I will measure the diameter of the femoral neck before preoperatively. If it cannot fit, I will choose another one. Also, also I have a question to you. Sorry, and you mentioned about 8 plate.
Yeah.
So my question is about how do you apply the two screws? You parallel or divergent or converge?
My practice, I use two parallel as much as possible. Because I mean, I do some reading. They said initially they thought the divergent screw give more better distraction in terms of faster outcome. But I mean, for me, in my experience, I do I mean, in divergent screw, my screw tend to break early.
So you mean you parallel?
I do parallel.
Okay.
If possible, I try parallel.
Yeah. Okay. That makes sense. Yeah.
Yeah.
Thank you.
Okay. Welcome.
Thank you for your attention. For me, it's very interesting webinar.
Yeah.
Dear doctors and their participants, thanks for your extremely heated debating. It is really an excellent ending for our lectures. Dear speakers and participants, would you like to put other questions? Okay, I think there is no more questions. Now the discussion section